Thank you. Our next speaker is Professor Gersak from Ljubljana. He will talk about his laparoscopic approach from the abdominal side to the thoracic cage. He has very nice, interesting procedure to show us about AF treatment.
Professor Gersak's going back in technology. The last time he was presenting it from his iPhone, so I'm disappointed you've gone back to an iPad. Maybe.
It's okay, I think it should stay. Can we have the... Dear ladies and gentlemen, Mr. Chairman, it's a pleasure and thank you to invite me to this meeting. The reason why I'm presenting from my iPad and not from my iPhone is because I didn't update the software so on my iPhone. Because if you want to be very close to technology, you have to update this probably every few months, and I didn't do that. So I couldn't agree more with my previous speaker that the hybrid approach is the way to go in the year 2014. And probably you should. Oh, this is. Can you do the Zoom or? Otherwise, half of my presentation won't be seen. Okay. Good, thank you. Thank you very much. But I couldn't agree less that it should be done thoracoscopically because, as you will find out from my presentation, I think that today, if you want to be truly minimally invasive, we should go out of the chest tubes, out of the drains, out of the pain. Even small punctures into the thorax should be abandoned. The treatment which we are going to use is for persistent or for long-standing, so-called, in the past, permanent atrial fibrillation. But let us see what is the percentage of the patients which are having paroxysmal and persistent. We can see that, according to the data, just about 12% of the patients have paroxysmal AFib, while almost 90% have persistent or permanent atrial fibrillation. So this is the group of the patients which we are targeting now for the last 5 years, and we start to use this technology in 2009. So the treatment available for those patients until now is just here with the yellow dots. They're younger patients. Their number is not so small. But nevertheless, there is a majority of the patients who are in this range and where the left atria are enlarged. And going back to the question which was asked before, we don't select the patients according to the left atrial size. Of course, if they will have a giant left atria, this is not, let's say, about 10 or 12 centimeters. We will not do this procedure, but this is something else. Normally, they don't present with such an atria in low AF. So we started 2007 with open chest pattern. In 2008, so 6 years ago, we still used the ports, but then in 2009, we abandoned the ports, and now our patients are having just a small incision in the abdomen. We're using this technology, which is an end-contact technology. This probe is sucked, it's vacuum assisted, and it's perfused, so we have irrigated radio frequency ablations. And this is the slide which is showing the directionality of these epicardial ablations. Each of the lesions is 90 seconds, and you can see this according to the time that just this part, which is on the ablating part of the probe, is heated, while the other part is not. It is very important to have the perfusion and suction, as was mentioned before as well, if you want to achieve good results. And this device is having good suction. It's 450 millimeters mercury negative, and a good perfusion. And this is how you can achieve a very good lesions. If you have anything else, like a poor suction or poor irrigation, you will not achieve results. Our pattern didn't change much since 2008. Now we are adding, of course, the green dots, which are hybrid dots, which is EP doing, and what is in blue, this is what we do today. And I'm going to show you a few videos, which is animations, to demonstrate how we do this. It's a very small incision, 2 centimeters below the xiphoid. Then we go through the abdomen, through the diaphragm, onto the backside of the heart. In the past we used the guiding wire, but now we don't use the guide wire anymore. We just do the parallel lesions, which are 3 centimeters long and about 5 to 7 millimeters in diameter. And in this case, we are isolating the posterior left atrium. We try to go really very close to the oblique sinus. And this is not the surgery, this is just the thoracoscopic, let's say laparoscopic procedure, so we don't dissect anything. We go very close to the coronary sinus on the left side, and then we go across the vena cava on the right side of the heart, and we do the anterior lesions in the Waterstone groove, and then again on the left side as well, as close as possible to ligament of Marshall. Those probes, those catheters are having the ECG recording possible, so we can really see that we are touching the heart, and if they don't touch the pericardium. And we have EP devices, equipment in our OR room. But of course, those lesions are not complete. We need electrophysiologists to go transfemoral, through the transfemoral vein, transeptal, and to complete the lesion set and to test our ablations with all the exit and entry blocks and all their equipment which they have. This is a single setting operation and EP procedure, at least in our hands, in our institution. But I know that there are some centers, there are 2 centers here in UK which do this type of surgery, both of them in London. They use a 2-stage approach. So what we end up on the posterior part of the left atrium is this: long linear lesions which are touching and which are really impossible to be done by the catheter alone. In this way, we were able to reduce the number of lesions according to the time, and we did now more than 300 cases, at least in our institution. But this is the case number from 1 to 50. You can see that the ablation time and the number of lesions is getting tremendously low. So sometimes now we do just 9 ablations, not more. This is a publication which was done in Journal of Cardiac Electrophysiology. This is our first results with the REVEAL monitors, patients with the AF burden less than 3%, almost in the 90%. So what can we say? What are the differences between the convergent procedure and all other procedures? We have a closed chest ablation, which is very close to the catheter ablation. We don't have any lung deflations. We don't have any dissections. This is very close to the catheter ablations. And of course, there is no cardiopulmonary bypass involved. But compare both 2 lines here and all the lacking parts here. So this can be performed in the EP laboratory, while the hybrid approach will have the chest, probably not. Patients can be extubated in the room and so on, and we don't put them in the ICU unit. So this is a big advantage of this approach. If you compare the patients, the percent of patients with the non-paroxysmal AF, which was in the catheter ablation, you can see that almost all of them were paroxysmal, but here they are persistent. And these are the results freedom from AF after 12 months. You can see that these are some centers around the world. There are centers in US and our center here presented. And everybody is reporting the same result after 12 months, not just our center. And what is the number of percent of the repeat catheter ablation procedures? You can see for the catheter ablation, they can be up to 90%, from 19 to 90%, while in the other institutions, which are using the hybrid convergent approach, we have a very small number of repeat catheter ablation procedures. Not zero, but still a very small number. Looking at continued antiarrhythmic drug therapy in the catheters, there is a lot, up to 60%, let's say, in this, but here pretty consistent, about 15 to 20%, and repeat catheter ablation the same as I mentioned previous. We published European multi-center study from 4 centers in Europe, and these are the results. 0% mortality, 0% 30-day mortality, or even more than 30-day mortality. 1 stroke, 0 TIAs, 1 tamponade, 1 pericardial effusion, 0 phrenic nerve pulses, and bleeding requiring transfusion, 2 patients. Not so bad if you say that this is the initial experience in some European centers as well. And this is the survival function, freedom from arrhythmias and interventions, according to 1 year, which is going to the scope of 80%. In conclusion, this is the lesion set which we use now, which is giving us really ablation in the posterior left atrium on the Waterstone groove, and the green dots showing the EP procedure. And let me show you a small animation why we think now, eventually after 5 years, why this is eventually working so good. So the heart is encompassed in the pericardium, and there are the pericardium reflections which really don't move. They are fixed structures. You have to cut them. So there is a huge stress on this part of the heart when the left atrium is enlarging for whatever reason. And this is going to cause the fibrosis later on, of course, in time. And this fibrosis is going to put a substrate on the potential beginning of atrial fibrillation, and you will have a small currents going around in those areas. And remember, the pericardial reflection, they cannot move. I mean, they are fixed structures. So when the catheter ablation is targeting those lesions, they are just isolating the pulmonary veins. And we as the surgeons know that isolating just the pulmonary veins is not enough. So they really don't touch this part here on the anterior aspect of the superior aspect of the left atrium, of course. But still, those areas here, which were the high stress areas around the pericardial reflections, will still be intact, despite the fact that those parts here will be fibrosing let's say in months or in years. So there is still some substrate going on, and this is no reason why those patients are coming back for the repeat ablations. Some ablations are seen here and here, but also the catheter ablation cannot be really wide, cannot be really consistent. There's just some small dots, and even if they are fibrosing, there will still be some potential for all those circuits to go on. So how we address those lesions with the convergent procedure? It's pretty easy, very simple, and I've showed you before. We do a long linear 3 centimeter lesions across the posterior left atrium. So we are addressing all those potential focuses for the later on ablation with this technology. And of course the cardiologists, the electrophysiologists are then connecting all those pulmonary veins which we didn't approach without dissections. When we have this pattern here, we can even expect the reduction in size of the left atrium, and of course we will demonstrate in the next papers for sure that the left atria are contracting with this technology and with this approach, and they are reducing even the potential future stress in this region. This is like a theory, but we are not just our center, but the centers around the world, mostly in US and 5 centers in Europe, are demonstrating this, and I do hope that in the next few years, many of you who are sitting in this audience will abandon opening the chest, even with the small ports. We did this 5 years ago. I believe it is working, but we have to go minimal invasive much more if we want to track the patients, because in perception of the surgeon and electrophysiologist, minimal invasive is completely different. For us, the ports are okay, but for the thoracic ports are okay, but for the electrophysiologist, they are thinking percutaneously through the groin. They don't want to open or even touch the thorax left to right. Thank you very much.
One question? Okay, Tufan again, but only one question.
Another point, in our study we do systematic MRI at 6 months and 1 year. And we noticed that two patients which were asymptomatic had up to 30%, one of them 30%, another one 20% pulmonary vein stenosis. If you go around on the top of the pulmonary veins, first of all, do you do MRI to check if you get asymptomatic pulmonary vein stenosis with this technique?
So first of all, we don't do NMR for this purpose. The second thing is we don't really ablate the pulmonary veins. What we do, we are ablating the antrum, so where the left atrium part, where the veins are inside. It's completely different than like EP are doing when they go really deep into the pulmonary veins. No, they are closer to the atrium.
So when you go on the top of the antrum, you can't see where you are sitting? These were not surgical videos, that's why I couldn't imagine very well how you can go on the top and where you are sitting to do your ablation.
If you are talking about the anterior aspect of the pulmonary veins, this is what I think.
Yes.
Anterior. So first of all, on the right side, you can really see where you are, because you can see everything: aorta, you can see the vena cava, you can see the pulmonary veins on the right side. On the left side, you can clearly see the left inferior pulmonary vein, but you cannot see the left superior pulmonary vein. This is why I told you, if you put the catheter close to the left superior pulmonary vein, there are two electrodes, and you can see that you are touching the antrum in this region, and this is recorded on the EP equipment. Why I do this? Because if you don't see, you can really ablate the pericardium or really very deep into the pulmonary veins, which is not good.
Thank you.
All right, thank you.